AMSN is proud to support the accomplishments of our members by providing them with resources that aid in career development and goal achievement through grants and scholarships.
Whether you're seeking funding for CMSRN certification and recertification, or support toward pursuing advanced degrees and entering the next phase of your career, AMSN is here to simplify your pathway to growth.
CMSRN certification and recertification grant applications are accepted year-round, and the application period for the Higher Education Scholarship and AMSN Student Scholarship closes June 30th.
To learn more and start the application process, please visit amsn.org/awards-grants/scholarships.
On this episode of Med-Surg Moments,
I'm trying to maintain that work-life balance. I'm a little spoiled. I've told you guys I work only weekends,
I just got back from my bachelorette trip. It was a Americade, which is like a bike week out there.
Our topic is how to work with challenging patients. We're opening up about our struggles and how we approach challenging patient interactions.
The biggest issue that we come across is patients that are physically aggressive or jumping into restraints, and I hate to restrain.
In a situation where there's a Dobhoff tube involved, I get why people go straight for because you don't want to lose that.
They were ranking us fairly low, and the patient said, "This is your job to wipe my butt."
This patient was ANO ×4 and liked to stay naked. So we leave the room. I see on the camera.
At the end of the day, you have to just let that be the end of it.
As a new nurse, you think you're doing everything wrong. So if someone says you're doing something wrong, you believe them.
I would love to hear your guys' tips and tricks for not taking these conversations personally.
This is Marcella,
Eric,
Trish,
Kellye,
Sydney.
and Haley. Welcome to Med-Surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud Med-Surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey. Our topic today is how to work with challenging patients. But before we get started, let's begin with some personal updates. Trish, why don't you get us started?
Okay. I've been able to, of course, spend some time with my lovely little granddaughter. And it was great over Mother's Day, spending time with my son, my daughter, and hang out with them. The weather here has been mostly lovely, and it's just been really enjoyable. This week, I'm looking forward to the North Carolina Nurses Association, the North Carolina state-based ANA. I am over the doctoral component of that. We're sponsoring a summit here at our hospital, and that's going to be really great on Thursday. So that's a little bit about what's going on. What's going on with you, Sydney?
Thanks, Trish. I don't have a very exciting update about the news story that I talked about last time, at least. I kind of chickened out on sending the news channel one of the engagement pictures, but they came out great, and I think his shirt was perfect, so.
I did just want to verify that Sydney did send us a picture of the shirt after the last recording, and it was a very nice, normal-looking shirt, and the fact that anyone would have any complaints about it is downright silly.
Either way, that news anchor was wrong. But I just got back from my bachelorette trip. There was about 11 of us, my 7 bridesmaids, and then a couple other friends, and we just had a great time. It was a Americade, which is like a bike week out there. And so on Saturday, we all dressed up as bikers in black leather and bandanas and things and hit the bars, and that was really fun. And then on Sunday, I don't know if you guys have seen this before, the backyard hibachi where they come to your house and cook hibachi outside. That was all I wanted to do. That was all I cared about. I told my maid of honor, I was like, we just need to go somewhere where we have access to hibachi. And it was everything and more. The guy was hilarious. The food was amazing. So yeah, it was a really special weekend. I felt very loved and very celebrated and very refreshed going back to work today. How about you, Haley? What's new with you?
Personally, for me, I am in the throes of potty training my 2-year-old. So that is, as you can imagine, so much fun. We got pushed back a little bit with the cast. So now we are going full force, probably like an 80% success rate. And when we started more intensively like 2 weeks ago. So I will not complain. He's honestly such a beautiful, perfect child. Everyone says that about their child.
Of course.
He is a beautiful, perfect child. Work-wise, we are ending up our fiscal year just about now. And I always get in the same weird rut at the end of every fiscal year. And it's awful to say, but I stop viewing patients as people and I start seeing them as numbers. Awful to admit, but I am working on balancing my work-life balance a little bit to kind of get me reset to see people as human beings again, rather than a fall or a happy or eclampsy. Now that I've been in this role for long enough, I know to prepare for it, that I need to get recentered in my why as a nurse. And my why is because I love to take care of people. Marcella, how about you?
Potty training, so exciting. I have 4 kids, so I've got one left that is not potty trained. He's about 2 years old, like yours. I kind of take my time. I really do take my time because the later you start, the more ready they really are. And I already told my whole family, we're not even talking about a dog because we have a yard now. We're never talking about a dog until everyone is fully potty trained. So we're getting there. We're getting closer, okay? I will have that conversation as soon as everyone is using a toilet. All right. So last time I saw you guys, the kids were signed up for spring stuff, and that's already over. Time flies.
Ooh.
So they finished their ballet and baseball. At the end of the ballet, my 4-year-old daughter did a little recital. It was the cutest non-choreographed thing I've ever seen. They're all like jumping. They don't know where to go. It was so cute. And baseball, this was more like a class, not necessarily a team. So on the last day, they play a full game. It's so funny. My son, he's 6, but he's never played baseball before. He's looking up at the sky. He's digging in the dirt. I'm like, dude, you got to run. He hit the ball. You got to run to home base. But it was great. They all got a little medal at the end. It was awesome. And now we're getting ready for summer camps. My 4-year-old daughter, she started preschool this year, but it was only 2 hours a day. So it was actually more like an overwhelm, leaving the house, taking her, and then leaving the house again less than 2 hours later. So this summer camp she's going to be in is going to be at least 5 hours a day. So this is my first time in many years where most of my kids will be out of the house for more than 5 hours a day, and I'll only have the little 2-year-old with me. I'm just so excited to like work on projects, either house projects or maybe tidy up my art desk. I'm excited for that stuff. And then at work, it's crazy out there. I think it's summer. They've been offering special pay every weekend. I'm trying to maintain that work-life balance. I'm a little spoiled. I've told you guys I work only weekends, try to do only one every Saturday, something like that. So why don't we move on to our topic? How to work with challenging patients. Let's be honest. We all encounter patients who are difficult to connect with or care for at some point. Maybe they're angry, demanding, non-compliant, verbally aggressive, or just seem impossible to please no matter what you do. And while it's easy to label someone as a challenging patient, the reality is that there's often much more happening under the surface. Fear, pain, trauma, loss of control, or frustration with their situation. That doesn't mean these interactions are easy. They can be emotionally draining, stressful, and sometimes even impact the entire unit. So today, we're opening up about our struggles and how we approach challenging patient interactions. Who would like to get this conversation started?
I would love to get us started. One of the units that I cover is the acute care of the elderly. We kind of run into the same rut over and over again because we're getting a lot of patients with dementia, a lot of patients with hospital delirium, and we honestly don't have a good standardized way of handling these patients to rule out other things. The biggest issue that we come across is patients that are physically aggressive and they're delirious. So we're jumping into restraints, and I hate to restrain, especially patients that are older than 65, because generally that makes their delirium much, much worse. But jumping into restraints before problem solving. So my biggest pointers that I give to all the staff that I encounter before they put into a patient into restraints is, let's troubleshoot why they're having this agitation episode. This probably isn't very normal for them. And if it is normal for them, we can contact their family to see what's worked in the past. But for the delirium perspective, are we bladder scanning them to make sure that they're not retaining? Are we making sure that they're not constipated? Are we checking them for an infection? There's a full laundry list of things that we can work up before we jump into restraints or, of course, Haldol. I like to avoid as much as I can.
Yeah, Haley, I totally understand what you're saying with troubleshooting first. I can't help but always think of my children and a baby. Okay, so I think of a baby and I'm like, okay, you're screaming, you're crying. Before I get frustrated, you got to go through all the checks. Are you wet? Are you hungry? Are you in pain? Like, usually these patients can't obviously clearly communicate it. So I can't help it but go through that kind of checklist. And I know that sometimes in a situation where like there's a Dobhoff tube involved, I get why people go straight for because you don't want to lose that. That's going to be the rest of your shift. Then you got to get it replaced, get it verified. And then they haven't started their food all day. And then you still have 4 other patients. If you need to put those on right away to prevent something dangerous from happening, okay. Yeah, but definitely troubleshooting those first.
Yeah, it's like understanding the why before we make a decision, or as with anything, understanding the why. That makes sense. And there's a gamut of all kinds of causes, and before, of course, restraints, or before we make decisions, like the decision algorithm for doing things. And especially with all levels of experience with nurses, getting them to understand that. So that makes the difference in teaching, education, and all those things. What kind of things are you guys seeing as far as challenging patients in your facilities these days? Is it just confusion or dementia? What kinds of things are you seeing besides dementia?
Dementia is always the big one. I feel like somewhere bordering between like dementia and delirium. But I mean, some people are just, I hate to say it, not the nicest, or they have an incorrect perspective of what the healthcare system should be, or especially what the nursing staff should be doing for them when they're in the hospital. And I think that type of patient can also be deemed as a quote unquote difficult patient.
Yeah, like their expectations for care.
Yeah, not just them, their families too. A lot of times, I know we're talking about difficult patients, but sometimes those family members are the really difficult ones to manage expectations of.
Yeah, agreed. Almost like a hotel type experience, a concierge type experience.
And sometimes even above and beyond a hotel type experience. I was just reading a patient satisfaction survey where they were ranking us fairly low, and it was because the nurse gave a little bit of pushback when the patient said, "This is your job to wipe my butt." But I'm like, it's not our job to wipe your butt. It's our job to keep you clean. And it's our job to encourage you to participate as much in your care as you can.
Right, because you need to do as much as possible for yourself to get well, for mobility, for healing, for not deconditioning. So, yeah, she was probably encouraging the patient to do for themselves.
Yeah, I think that's what some patients fail to realize, is that they think their goal is to sleep and relax and, oh, I'm sick, someone bring me soup, like their mom would at home. But a lot of times it's like being in the hospital is intense. We got medicine for you to take in. Wake up, you got PT. Okay, now wake up, you got OT now. Okay, the doctors are back and I need to test your swallowing and we're going down for an x-ray. And it's just like, we are here to get you better. And better is not always easy as laying in bed and having the nurse bring you your soup.
Yeah. Fun fact, I was walking out this week. It was, I think, 2 days ago. And I was behind a patient's family And I heard the discussion about they've just been waking her up so often. I had no idea who they were talking about, but I certainly heard the discussion. That's perception. And of course, I'm sure we don't always do that great of job of explaining, what we're doing and why we're doing it. And I'm sure we explain what, but maybe not why we're having to wake them up every 4 hours or whatever. I'm sure that was family talking in front of me, but that's an example of what goes on. And we've all been there.
Trish, that kind of highlights one of the main branches to this topic, communication. So I feel like there are so many different kinds of challenging, like we've talked about. There's someone who's flat and withdrawn because they're dying of cancer. There's someone who maybe history of drug abuse and come back to the hospital. In another hospital that I was working at is completely different kinds of challenging patients than what I have at my current hospital. So at the last one, it was downtown Chicago. It's newer facilities. It's lovely. You have a mix of higher income people and then homeless people. It's totally full range. We give a lot of free care at that hospital. So of course, people are going to come back again and again. We have whole systems for the patients that keep coming back. They usually have chronic illnesses, but also it's comfortable. It is kind of a hotel experience. You get your own room, TV, cable, even tablets we hand out now. And we are expected to answer you in a certain way, give you what you ask for. So I remember at that hospital, we had implemented cameras in every single room because of COVID, which is a whole nother topic. I feel like sometimes in the state of emergency, we start encroaching on privacy and then it stays that way. And once you open those doors, they don't close again. And sure, it was really convenient. It was awesome. And I will say one of the things, it did enhance safety. So one example I will give is that you've had patients with drug abuse history. You're kind of more careful of checking the room, especially if they came in intoxicated or with the police. You check the room, you check their belongings. And this had already happened with this patient. And this patient had already been there for weeks. And sure enough, I leave the room. And first of all, this patient was ANO times 4 and liked to stay naked. So this is just an example of something. These conversations happen again and again. This is not appropriate. We leave the room. I see on the camera a flame. Drugs start happening. Okay, I need to call security. This is not something that I can de-escalate. Some advice would be you stay calm. You don't bust in. You're not his mom. You're not going to go in there by yourself. You go in with security. You let them know the situation. Once again, the reminder is you're not their parents. You're two adults and then you have backup, but you can still professionally say, this is not acceptable. This is what's going to happen next. So these are the next steps. In that situation, the communication can still stay on track professionally and compassionately in the sense of don't take it personally. Lay out what's going to happen next. So this is what you're doing. This is how we handle this situation. And if we don't follow these directions, once again, I can't help. I go back to kids. This is how I do it with my kids. If I'm taking it personally, it's because I'm tired. It's because I'm overwhelmed. But if I don't, the de-escalation can still happen no matter the reason that it's happening. And something I love to do at the beginning of the day with all my patients, whether they're schizophrenic or withdrawing from substance abuse, introduce yourself and verbalize every single thing you're doing. Even if they're not fully A&O, I verbalize everything I'm doing. Even if sometimes they're unable to assess, but we don't know why. You don't know what they can hear. You don't know what they can understand. And if family is in the room, you're verbalizing it for them too. So I verbalize everything I'm doing, the plan for the day, and then the classic, if you don't know the answer, you tell them you're going to get the answer. So just never taking it personally, even when they get a little spicy on you, just stay calm. I agree, sometimes this is pretty sucky, but this is hospital policy, or this is just the time that it takes for an exam to happen. So anything like that, communication is first, laying it out, kind of a map for them to see what happens. And I feel like it can't prevent everything, but it gets everybody on the same page a little bit.
That was very well said. I have been a nurse for 10 years. To this day, I still take them personally and I bring it home with me. And it's something that keeps me up at night. I would love to hear your guys' tips and tricks for not taking these conversations personally.
I was actually telling one of my texts today, my old catchphrase when I was discharging people, I was like, it was nice to meet you, but I hope I never have to see you again in the nicest way possible. Because, I don't want to have to see you again because that would mean you're in the hospital. But some of those patients, you really mean it. And I think that's kind of the way you have to take it, not personally, is this is a very temporary state. It's 1 12-hour interaction or it's 2 weeks of 12-hour interactions. But eventually, this person's not going to be in your life anymore. It's not like it's a family member or a friend or someone. It's a professional relationship that's hopefully extremely temporary. And at some point, you just have to kind of make light of it. We had this one patient one time that was with us for a very long time. He went to the ICU, and then when he came back, he was very upset that he couldn't keep his ICU bed because I guess those were more comfortable than our beds. And then he was upset because when he was with us the last time, he was able to have 2 end tables. But this time, our unit was full, so there were no tables to spare. And I was charge nurse that day, and so I went into his room because he was screaming about his end tables. And I was like, hey, look, there's no more end tables. We are full. I have no tables to spare. The only place I can go get some end tables from is from the pediatric ward. Do you want me to go steal tables from kids? And he said, yes. And I was like, okay, we're not doing that. You will be okay without your end table. You just got to realize some conversations you can't win. And that's kind of how I at least try to take it not personally. It's like, well, what? I get to go home after this.
Sydney, in regards to you see them for a limited time, people say, why do you like full pool? That sounds miserable. Even if I work 2 days, I usually try not to work multiple days in a row because I've told you I'm a spoiled brat. But I'm PRN and I work mostly once a week. Part of the benefits of flow pool is that you will for sure, no matter how many shifts you work in a row, you will likely not see that person again the next day. It's awesome. I do like it. I started my nursing career, I've told you guys, on that pulmonary step down, and I worked there for 3 years. And on that unit was really big examples of taking work home with me, where I had nothing left for my family at the end of the day, because these patients were there for months at a time. And there were patients that did stress an entire unit of nurses. And there was one patient specifically that ended up being there probably at 6 months total. And she was technically dying of pulmonary hypertension. She was on a continuous infusion on that unit. We were the only unit that could take this infusion. It cannot be stopped. It cannot be flushed. It cannot be anything because they'll go into flash pulmonary edema. It's really terrifying. And unfortunately, this woman did get a diagnosis of end of life within a few months. And she basically was very demanding. You better do this for me or you're a bad person. And we saw her every day. And when we would try to set boundaries that were professional boundaries, like, we have other patients. This is how you call us. This is how you talk to us. This is what we can do for you. Even the doctors didn't give us the backup. It became a gossiping situation. Honestly, in the midst of that, I ended up transferring to another unit. And it wasn't specifically that one case, but it was the case of these long-term patients that we're taking home with us. They're like, you don't get to leave. You come back and they're there again and again. And you don't want to lose that compassion. So once again, me selling float pool, even patients you love, I take them home with me too. I have a problem. That's why I can't be in pediatrics. I want to take everybody home with me in my heart, in my mind. So float pool helps me let that go for sure.
I think for all nurses, the best case is that we just know not to let those challenging patients stay with us. Our best medicine is to let it go. At the end of the day, let that be the end of the day. Whether you work float pool or whether you work one of those chronic long-term units. I was the nurse manager over one of those pulmonary units for 10 years too. And those are tough. But at the end of the day, you have to just let that be the end of the day. and you just have to let it go. Haley, I think you do a better job of that than you think you do with that precious little one and another one on the way. Just let it go and let that conversation be that conversation. And then just like we were practicing that hand washing and then like, oh, okay, woosah, we're done with that. And then we're on to the next thing. We have to do that. And I think we have to tell the next generation of nurses to do that too, because that's the only way we're going to survive as nurses, whether it be, the challenging high expectation patient or the challenging chronically ill patient. I don't think is going to change or get easier for us. And I feel like as time goes on with different diagnoses and different things that are going to come along and that are coming along, that will continue to develop. What other things with challenging patients do you see on the horizon?
Virtual monitoring. It's helping and also avoiding sometimes. But when you don't have enough staff, safety is more important than doing a perfect communication and watching type job, intervention job. Safety is number one. So I think if it means someone's watching them, making sure they don't hurt themselves, then the virtual monitoring is awesome. But if it means you don't go in there because you got the virtual monitoring, then it's a down. So it's really balanced like everything else for sure.
Mm-hmm. Young nurses like you, I think there's really great hope with innovation, things that you guys can come up with. I listen to your brains and they're so fast. You guys come up with all this great innovative ideas. So I'm so hopeful that you guys will think of innovative things with challenging patients.
We're just going to have to patent the de-escalation robot.
Oh, yeah. That's a great idea.
A $1 million idea. Don't know how it's going to work. We'll figure it out.
Sure. I repeat, first safety first, and then using those techniques that we talked about. A unit plan for something like that. Like I said, the example where the doctors didn't back us up. But I have a lot of other experiences where sometimes either whether it's psych or just the primary doctor, we all come up with a plan, and then there's a sticky note in the Epic chart or a note that just says, when you enter the room, do these things, and everyone has to stay on the same page.
Yeah, like a plan of care.
Super crucial. And then not taking it home with us. The only thing that helps me with that sometimes is saying a prayer for them, because otherwise I will be keeping them on my mind, whether it's because I took something personally, which is more rare now that I have more experience. As a new nurse, you think you're doing everything wrong. So if someone says you're doing something wrong, you believe them. And now as an older nurse, I'm like, that's ridiculous. That's not what I'm doing. So I don't take it personally. But then the last one is sometimes if you do all these things with this patient, like map things out, tell them I know that sucks, they do respond a little bit to you. And then it becomes like, I remember one woman, she ended up telling me like, oh, it's because I was in this car accident and then my husband died. And they kind of open up and it's like, okay. And then we're praying together and it's like, okay, I understand that this is what you're going through. Can you work with us? I know not all the nurses are going to talk to you like me, but it doesn't mean that you have to do this every time. So when it's possible, not all patients are receptive, but when it's possible, you can break down some of those barriers if you have time. That's the crucial thing.
That's a great point. Yeah. So just getting to them and saying, hey, I understand, but you matter. I hear you. What you've been through is really difficult. It's okay. And you matter. And I don't understand because I've not lived through that, but you do matter.
On that note, let's go around and have each of you share your biggest takeaway from this conversation. Trish, what are your takeaways?
I think it's really great to remember that there's multiple different kinds of challenging patients. But in essence, if we remember that and remember that they all are coming from different reasons for being challenging, and just center and remember to listen to them and then to not take the negatives back with us, then we'll be okay. And really, that's the essence of caring. That's why we do what we do.
For sure. Sydney, how about you?
I think it's just so important to remember how important communication is, whether it's communicating with a difficult patient, communicating with the families, communicating with your team when you need help, just keeping that open line of communication of managing expectations. And I think that's really important for managing those patients.
Haley, what stood out for you the most?
I think this episode was a nice reminder that empathy is definitely one of my greatest strengths as a nurse. And it's also something that I need to make sure that I'm keeping in check so that I'm not bringing home these difficult situations with me. And Marcella, I loved your point about making sure that we're communicating as much as possible, especially in that dementia and delirium population, because we're not sure what exactly they're picking up on, but it can help level set and help prevent agitation in real time.
As for me, even though I'm in full pool, I still struggle with taking my patients home. In my mind, I'll just be staring into space and my husband's like, what's going on? And I'm like, well, this lady at work today, or this lady at, this patient last week even. And I know that we all have to recognize that that's taking energy. Thinking about these things takes physical energy away from us. So I definitely will keep that in mind more, I think, when I'm headed home. And remember that I can trust my team when I leave. That continuation of care, I can trust in that. Even though I'm on a different unit all the time, us nurses are smarties. We're smarty pants. So I got to let it go, trust that someone else will take over for sure. To our listeners, thanks for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of Med-Surg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to Med-Surg Moments wherever you listen to podcasts.
To reach us, use hashtag MedSurg Moments on your social post.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We're all AMSN members, and if you love Med-Surg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the Med-Surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Sydney,
Eric,
Trish,
Kellye,
Haley,
and Marcella. And always remember, Med-Surg Moments is a moment in our lives and a moment in our Med-Surg careers that makes a huge difference.